Hello, friends. Welcome to this online initiative by the Indian Arthroscopic Society, where we would be presenting various video techniques for different surgical procedures. I'm Dr. Nilesh Kamat from Pune, working in Sancheti Hospital and Jahangir Hospital. Today, I shall be presenting video technique for arthroscopic acromioclavicular joint stabilization. We all know that the acromioclavicular joints ligaments provide stability in a superior and a posterior direction. The superior AC ligament contributes to 56% or to the posterior translation of the clavicle, whereas the posterior AC ligament is the weaker ligament and it contributes to 25% resistance to the anteroposterior translation of the clavicle. More important are the coracoclavicular ligaments, which are responsible for both the inferior subluxation of the AC ligament as well as the antero-posterior motion when these ligaments are injured. The Rockwood classification is the standard classification, which is in the increasing grade of severity, where grade 1 is the least form of injury to the AC joint, whereas grade 6 is the highest form of injury to the AC joint. What does present literature discuss? We all know that there is a general consensus for non-operative treatment of Rockwood type 1 and 2 lesions, initial non-surgical treatment for type 3 lesions, and operative interventions for Rockwood type 4 to 6 lesions. However, further research is needed to determine if differences exist regarding early versus delayed surgical intervention and anatomic versus non-anatomical surgical techniques for treatment of patients with AC joint dislocations. So the AC joint over the years has been fixed with various modalities. Whenever more than one type of fixation is available for a particular pathology, it still means that the treatment is in evolution. In the recent past, there have been strong proponents of arthroscopic fixation because, as shown by Professor Imhoff, there is nearly an 18% incidence of concurrent intra-articular injuries. And hence, they strongly recommend an arthroscopic fixation using either the dog bone button fixation or the AC joint tightrope. Today, we'll be presenting a case of a 24-year-old male who is right hand dominant involved with a right road traffic accident with a grade 5 AC joint dislocation. Primary x-rays show as if there is a grade 3 dislocation, but on stress views, you can see that there is more than 100% translation of the width of the clavicle, categorizing this as a grade 5 AC joint dislocation. All our patients for these cases are operated in a beat chair position. After positioning the patient through a standard posterior viewing portal, an arthroscopic evaluation is done to rule out any concurrent pathologies. The posterior labrum along with the axillary pouch is seen, following which the anterior labrum with the AIG-HL is then visualized to rule out any concurrent instability. The long end of biceps along its entire course as much as visualized is seen with the medial and lateral pulleys. And then attention is paid onto the rotator cuff insertion, both the subscapularis as well as the supraspinatus, to rule out any concomitant rotator cuff tears. After a satisfactory evaluation, the first thing is done is a high lateral portal is taken in the rotator interval. The idea is to keep the portal parallel to your subscapularis because eventually this is going to be the visualization portal. You start clearing off the rotator interval till you start seeing the base of the coracoid. Once the base of the coracoid is seen, then you reorient yourself to the anatomy. That's the tip of the coracoid with the conjoint tendon. You then have on the lateral side, you have the CA ligament, and on the medial side, you have the pectoralis minor insertion. Staying in this position, another portal is then created inferior and lateral to the pre-existing portal. Then your camera is then changed to the anterolateral portal and the inferior portal becomes your working portal. So to keep you oriented, This is going to be your visualization portal, and this is going to be your working portal. When you shift the camera, this is the orientation that you would get from the anterolateral viewing portal. This is the posterior referencing from where the Wisinger rod is coming in. That's the face of the glenoid, that's the humeral head. As you move further ahead, you will realize that what you can see, the cannula is there in the inferior working portal. The probe is on the subscapularis. And as you look straight forward ahead, you should start seeing the genu of the coracoid. The undersurface of the coracoid, which is a U-shaped position, is extremely important when you're doing arthroscopic stabilization of the AC joint. Keeping complete visualization of the undersurface of the coracoid, using a commercially available zig, you're then going to insert a guide wire, which is going to be passing through the clavicle into the coracoid and exit along the undersurface. This is the orientation of the zig, where you hook the end of the zig along the far end of the coracoid, and you allow the guide wire to pass right in the center to the laser mount. Once the guide wire inserts in under vision, at that point of time, you clean the cannulated 3 mm drill bit, and you pass a nitinol loop through this cannulated guide wire, which is then retrieved through the posterior portal. The dog bone button with the two preloaded fiber tapes are then retrieved through the loop and passed across the undersurface of the guide wire. The animation depicts this further. The nitinol loop is then taken out from the anterior-inferior portal, loaded with the tape with the button, and then the button is then passed to the undersurface of the coracoid. It is important to allow gentle positioning of the dog bone button to let it be flush with the undersurface of the coracoid. At this point of time, we always visualize using intraoperatively using fluoroscopy to note that the reduction is complete and there is no residual subluxation which is persistent. Then a superior incision is taken on the clavicle, and then the second dog button is passed with the same fiber tapes and is cut flush after tying your respective knots. The knots are then buried under the subcutaneous tissue, and then the skin is closed with a non-absorbable suture. This is how the final picture looks like. The operative scars in these patients are cosmetically appealing without significant morbidity. This is the follow-up of the patient at around 8 weeks without any pain, without any discomfort. The post-op X-rays show congruent reduction of the acromioclavicular joint with satisfactory position of the two dog bone buttons, one on the undersurface of the coracoid, one on the superior surface of the clavicle. The post-op protocol for these patients is keeping the arm in an arm pulse sling for 4 weeks. Phase 1 exercises are initiated immediately. Closed chain range of motion exercises to prevent anterior capsular contracture. And gradually you progress to full range of motion over 12 weeks with strengthening of the shoulder muscles. Thank you for your patient hearing.